Greetings, and welcome to this conference hosted by MS Focus Multiple Sclerosis Foundation. I am your host, Chris Payne, editor for MS Focus. I'm joined by Dr. Ben Thrower, who will be sharing valuable information regarding managing your MS spasms and stiffness. After his presentation, we'll open it up to your questions and comments. Now, I'm delighted to introduce our speaker. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. And we're proud to say that he's also the senior medical advisor for the Multiple Sclerosis Foundation. We're pleased to have him join us this afternoon. Dr. Thrower, thank you so much for being with us, and I'll turn it over to you.
Great. Thank you, Chris, and thank you to everyone else behind the scenes at MS Focus. So as Chris said, this afternoon, we're going to talk a little bit about multiple sclerosis and spasticity/spasms. And if the gods of technology are going to cooperate with me, I'm going to try to get my screen up and running here. So Chris, can we see that okay?
Yep, it works.
Awesome. All good. Perfect. So spasticity is something that is fairly common in multiple sclerosis. And on the other hand, it's also something that can be a little bit difficult and mysterious in terms of how people experience it, how you relay that experience to the medical community, and what we do about it. So spasticity comes from the Greek term spastikos, which means to draw or tug. It is a condition that affects the motors or muscle system. When we're speaking to medical students or nursing students, and we ask them, how you would describe spasticity on an examination on one of their tests, the strict medical definition is that it is a velocity-dependent increased resistance to passive stretch. That velocity part is important because when we say velocity-dependent, we mean if you were to move your arm or leg and it's affected by spasticity, if you move it slowly, you're not going to detect as much spasticity. If you do a quick movement, then that muscle's really going to tighten up. That has implications for when we think about stretching and physical therapy for spasticity. You also tend to get a hyperexcitability of the stretch reflexes. Stretch reflexes are also referred to as deep tendon reflexes. So when we tap on your knee or we tap on your elbow with the reflex hammer, how much that muscle moves in response to that tap is a deep tendon or stretch reflex. And with spasticity, we tend to have sort of an exaggeration or a heightening of those deep tendon reflexes. So spasticity versus spasms. Spasticity is the chronic state of the muscle being tight. A spasm is that wave of tightness, or like a Charlie horse that can occur, frequently fairly painful when you have that wave of spasming. So I was the lead researcher on a study that we did last year looking at how people with MS report spasticity and spasms and how that sort of, how they experience that and report it interacts with the medical community. And what we found is that people frequently have a very hard time describing their symptoms. Some people don't describe spasticity as spasticity. They never use that word. They may actually use terms like a heaviness or tightness. Some people experience spasticity as a form of weakness. And that difficulty in sort of explaining yourself and describing your symptoms may lead to the symptoms being underreported to your healthcare team and therefore the symptoms not being appropriately managed. So when we think about what causes spasticity, normally there is a balance in the human body between flexor muscles and extensor muscles. Everything is sort of in balance, and that sort of balance is controlled by the central nervous system, the brain and the spinal cord. And when you have an injury to the brain or spinal cord, whether it's a multiple sclerosis lesion, a spinal cord injury, a stroke, a brain injury, you are throwing that balance sort of out of alignment. And now you're sort of letting either extensor or flexor muscles sort of be overactive. So you can have spasticity and spasms due to injuries in the brain because now you're taking away that normal inhibitory influence to the brain over muscle excitement. And you can also have spasticity from spinal cord lesions. And again, what you're doing is by putting a lesion in the spinal cord, you're interrupting the ability for the spinal cord to send inhibitory signals downstream to the alpha motor units in the muscles. So what does that end up looking like? So if you had to describe classic spasticity affecting one side of the body, what you'll see here in this cartoon is the gentleman has his arm carried in a flexed position, whereas the leg on the affected side tends to be extended. So spasticity most frequently manifests as increased extensor tone in the legs and flexor tone in the upper extremity, the elbow, the fingers. So some of the other things that we see with spasticity, we mentioned hyperactive reflexes, muscle spasms, clonus. So clonus is a deep tendon reflex that keeps firing over and over again. So normally, for instance, if I tap on your ankle to test your ankle reflex, I'm going to get sort of one jerk or one bounce. With clonus, that the foot keeps bouncing again and again. People experience this in real life by you get your leg in a certain position and the leg starts bouncing and you can't stop it until you actually move the leg or push down on the leg. That's clonus. That's a deep tendon reflex that's firing over and over again. Spasticity can be painful. It can impair voluntary control of the skeletal muscles. So if you think about this gentleman, one of the ways sometimes that people will experience spasticity is to say, my leg is so heavy, when in fact there may be true weakness there, but what may also be happening is that spasticity is driving the foot down into the floor so that it's difficult to bend the leg and move the leg because of the spasticity. Sometimes we don't really know how much weakness a person has until we get their spasticity managed. Another form of a kind of a unique form of a spasm is the MS hug. So many people with MS experience this. It's a tight sensation either around the chest or around the abdomen. You know, when you say MS hug, you think that would be a pleasant thing. Hugs should be good, but this is more like a hug by a grizzly bear. So it's frequently not pleasant, and that can be a form of a spasm. So it's odd to think that spasticity could, in some ways, be good, but there could be some positives to spasticity. It does help maintain muscle tone. It can actually improve circulatory function, may help prevent the formation of deep tendon reflexes. And some people may actually use their spasticity to help with activities of daily living. So, what do we mean by that? So if you have increased extensor tone in the legs want to straighten out, and you also have weakness in the legs, when you transfer, say you're going from chair to your car, you may actually use that extensor tone to help with transfers. So you may be able to stand up better because of that spasticity. Sometimes when we take all of that extensor spasticity away in the legs, we make the legs looser, but sometimes we make people less functional. So now the person is kind of floppy like a rag doll, and they don't actually transfer as well as when they had a little bit of spasticity. So there are negative consequences to spasticity as well. You know, too much spasticity can interfere with mobility and exercise, range of motion, can make some activities of daily living very difficult. So let's say that person who has increased extensor tone in the legs, they're using a little bit of it to help, say, transfer from their wheelchair to the car, but now they're in the car and the legs won't bend. So their legs are stiffened out. It's hard to get into the car seat, Turning over at night is more difficult when the legs are super stiff. The increased flexor tone, like you see in the picture here, obviously is not usually of any benefit to a person. It significantly impairs what the person wants to do with activities of daily living. Can make it difficult for caregivers to help with transfers and hygiene and whatnot. So we frequently say that spasticity and spasms are stimulus responsive. What we mean by that is that there are things in your environment that can aggravate spasticity and spasms. Probably the big one would be urinary tract infections. Any infection can do it, but urinary tract infections would be one of the most common ones. Anything that kind of throws you out of your normal homeostasis can worsen spasticity and spasms. It could be kidney stones, so a woman having her period, constipation, any sort of infection. It's even things like ingrown toenails or clothing that's irritating to an extremity can do that. Changes in temperature. While we know that a lot of people with MS have heat sensitivity, some people with MS also have cold sensitivity, and when they get chilled, their spasms or spasticity may act up. So when we think about managing spasticity, we usually think of sort of a stepwise approach. And sort of when we start at the bottom of this escalating treatment paradigm, at the bottom would be removing those noxious stimuli. So if you're having urinary tract infections or any sort of infections, as much as we can, we'd like to prevent those. We want to make sure that you're in a comfortable seating position, that you don't have braces or clothing that are irritating to the skin that might kick off those spasms for you. Next notch up would be real rehabilitation, physical and occupational therapy. We really like to get the physical and occupational therapists involved for a number of reasons, which we'll go into in just a moment. We're going to talk some about the oral medications that we use for managing spasms and spasticity, and then we'll get into more aggressive treatment options, including things like intrathecal baclofen. At the center of all of these treatment options is the individual with MS living with spasticity. So this is a great example of shared medical decision making. We want to make the person with MS and their significant others aware of what the treatment options are, and really come with putting your healthcare team together, come up with a good treatment plan that lets you take advantage of all of these different treatment options. So ultimately, the goal is to decrease spasticity and spasms and to improve function. Where one of the reasons we like to get therapy involved early is to help us sort of gauge how aggressive should we be with medications. Should we use medications at all, or can we manage it all with just stretching and range of motion exercises? We'd like to decrease pain. We like to reduce the likelihood that you end up with contractures. So a contracture is the result of chronic untreated spasticity. So if your joint is held in an abnormal position, for instance, let's say your wrist is flexed over long periods of time from spasticity, eventually those tendons and ligaments start tightening up, and you may end up with a contracture or a more permanent of state of that joint being in an abnormal position. So rehabilitation is something we really want to take advantage of as early as possible. Stretching through both the therapist and then giving you stretching exercises for you to do at home, or something that's going to be vitally important. One of the things I would mention under stretching is that when you look at what the therapist is doing here in this picture, this is sort of the classic stretching. So this would be what we call static stretching. You're putting the joint, the extremity into a certain position, you're stretching that muscle, and you're holding it there for a period of time. There's another form of stretching called dynamic stretching. And for sure, we want you to take advantage of the static classic stretching, but some people benefit from dynamic stretching as well. Dynamic stretching is stretching through range of motion. So this is typically done by a trainer or a therapist, and they're going to have you stretch while you're moving that extremity. There are facilities now that you can go to. So you may be able to do this through the physical therapist, but some people actually go to places like the Stretch Zone or Stretch Lab. These are, sort of places where you go, you pay a certain amount, you go through a 30-minute stretching routine. You can have them work on your arms, your legs, all of the above. And so some people will take advantage of this maybe once or twice a month as sort of the icing on the cake to your stretching program. We want the therapist to work with you on weight bearing. They may help coordinate Botox injections. Serial casting is something that's done for more severe spasticity. So for instance, if you're getting into a position where you're seeing some contractures, that joint is in an abnormal position, what the therapist may do is sort of use a splint or cast to try to stretch that joint out a little bit, bring you back at some point later, maybe days or a couple of weeks later, and now that that joint is stretched a little bit, put a new cast on, push that joint just a little bit closer towards a normal position, and do that several times until you are hopefully sort of relieved of some of that contracture or spasticity. Aquatics or pool therapy is something we take advantage of because you can sort of unweight or the person and decrease their fall risk and maybe be a little bit more aggressive with range of motion in a pool. So two just very simple stretching exercises if you're dealing with any tightness in your legs. So when you think about tightness in your legs, you're going to tend to have tightness in your calf or gastroc muscle, and that's going to want to push your foot down, and you're going to have tightness in your quads that's going to want to straighten the leg out. So these are some exercises that you can do at home that are going to help work on those. I particularly like this one with either a towel or an exercise band to kind of stretch that calf muscle out. This is sort of the runner's stretch. For some people, it's easier to do it lying down, so you're not having any balance issues. Remember, we said early that spasticity is velocity dependent, meaning that if you move that muscle during a stretching exercise in a very quick, herky-jerky fashion, that muscle is going to tighten up on you. So when you're doing any stretches, you want to be very slow and gentle. If you're having someone assist you, and remind them that they need to be slow and gentle with that stretching exercise. Otherwise, the muscle is going to let you know that you move too quickly and spasm on you. So these are our classic medications that we would think about for managing spasticity. So we've got baclofen as our old standby, been around forever. The second line, these would be your benzodiazepines. So diazepam or Valium, clonazepam, Klonopin, lorazepam, Ativan. These can be great muscle relaxants. Not probably the first thing we're going to go to because of some potential for tolerance or addiction. Dantrolene is an old oral medication, probably not used as much in our MS world as it is maybe in spinal cord injury or stroke, but it's certainly something to be aware of. Tizanidine, I would say after baclofen, is probably one of the most commonly used medicines for spasticity and spasms. Keppra, levetiracetam, is an anticonvulsant medication um, that has been shown to help with spasms in some people. And then we get into the cannabinoids. These are your THC, derivatives, and so it could be the actual plant material. It could be this oral THC, synthetic THC, dronabinol or marinol. Unfortunately, we may need to take Sativex off the list here. So this Sativex is a sublingual spray of THC. Is approved in many, many countries around the world for spasms and multiple sclerosis. Unfortunately, the company made the decision a couple of years ago to not pursue FDA approval in the United States. If we have any folks, though, listening from Canada or Europe, you do have it available there. So With both baclofen and tizanidine, our most commonly used medications, we typically like to start with a low dose and go very slowly. And so what we're trying to do is find that sort of sweet spot where we're managing the symptoms but avoiding side effects. And we sort of halfway jokingly say we're going to titrate upwards on the dose until one or two things happens to you. Either you're happy with the degree of symptom control or you're starting to get sleepy from it. And there is tremendous variability from person to person in where you're going to hit that spot. We do unfortunately see some people who just never can get to a dose with baclofen or tizanidine where they have symptom control without drowsiness. Um, both baclofen and tizanidine have different mechanisms of action. Contrary to what some insurance carriers say, you can use them together. We sometimes get pushback from insurance carriers. They'll say, well, either the person's on baclofen, they can't take tizanidine, or vice versa. When in fact they do have different mechanisms, and there are people who do benefit from being on both medications. Um, be aware that sometimes with baclofen, as we go up on the dose, we seem to sometimes unmask weakness. And so, we may get control of spasticity and spasms, but we may make the person less functional because we're sort of uncovering a lot of weakness. One of our precautions with baclofen is that if you are on a regular oral dose, you probably don't want to stop that abruptly. And by regular, I mean taking it 3 times a day. If you're taking just a dose at bedtime, you probably could stop that without harm. What we're nervous about if you stop a significant dose of baclofen abruptly is there is some risk of seizures. Cannabinoids and spasticity. So there's quite a bit of research out there showing that mixtures of CBD, THC, whether it's by mouth or in an inhaled form, can be effective for spasticity management. They tend to work better for spasms than for the chronic state of spasticity. Um, that my personal observation, and I think research would back this up, is that CBD products alone tend to not be as helpful for spasticity. We tend to think of CBD as something that we might use to help with sleep, to promote better sleep hygiene, and also something that seems to help with low-level anxiety in some people. There was a 2019 review that looked at 14 studies of oral or sublingual forms of CBD and THC, and found that there were significant reductions in and how patients reported spasticity and spasms. Botox injections. So botulinum toxin this is a toxin produced by a bacteria that normally they think of botulism as something that you don't want to have, but medically we can take advantage of it. It does have a muscle paralyzing property. That's how the disease works, but we can actually use the botulinum toxin in very limited ways to treat spasticity. So there are several different brand names. Botox and Dysport are two of the more common ones. Botox is also used from a cosmetic standpoint to help treat wrinkles. It is FDA approved for migraine headache management. So a lot of different reasons why we might think about botulinum toxin. Typically, you're going to use it to treat focal spasticity. So because you are temporarily paralyzing that muscle, we have to give thought to, is this a muscle that we can have you do without? So obviously we wouldn't want to paralyze a muscle that you need for function and activities of daily living. Typically, this is done on an every 3-month basis. So something that is still in development is a type of therapy called cryoneurolysis. So this is the concept of applying extreme cold to a nerve to temporarily damage that nerve and decrease the ability for it to send signals to a muscle. This is FDA approved for pain management. There is research looking at this procedure for spasticity. It is not yet FDA approved for that, but you are seeing some growing research. When it works, it seems to work for quite a long period of time, maybe up to a year after a treatment. And then we're going to finish up with intrathecal baclofen. So this is what an intrathecal baclofen pump looks like. So it's about 3 inches across. It is surgically implanted on one of your flanks, just under the skin. There is surgical tubing that runs under the skin and then delivers concentrated liquid baclofen into the spinal fluid at about the L4-5 level in your lower back. So L4-5, if you touch the top of your hip, your pelvis on your side, and you move your hand around to your back, that's about L4-5. So that's where this tubing is going to deliver this concentrated liquid baclofen. So why would we want to do this as opposed to oral baclofen? So when we take oral baclofen by mouth, a certain amount of it is absorbed in the intestine, and a big proportion of that is absorbed into your bloodstream, goes straight to your liver, and is metabolized and never does anything good for you. So that's called the first pass effect. So a lot of what we take by mouth as baclofen really never gets anywhere. It doesn't do what you want it to do. Um, Oral baclofen, so once it's in your bloodstream, it's not very well able to cross the blood-brain barrier. So you want baclofen working at the spinal cord level, and it's actually not very easy for that baclofen molecule in your bloodstream to get where it needs to be. So we really want it working at your spinal cord. A certain amount of the baclofen that you take by mouth is going to cross the blood-brain barrier and go into your brain. That's not where we want it working. That's where a lot of the sedation comes from. So when we take oral baclofens, not all of it's getting where it needs to go. Some of it's going where we don't want it to go. And so, the doses tend to be much higher with oral baclofen than what we would use if we just put it in your spinal fluid. So if we put baclofen into your spinal fluid or into the intrathecal space, the doses are a small fraction of what you would take by mouth. It's going exactly where it needs to go, into the spinal fluid to work at the spinal cord level. So you tend to avoid a lot of the sedation that you would see with oral baclofen. So having a baclofen pump put in is obviously, it's not a small undertaking. This is a surgical procedure. There is the risk of general anesthesia. So we want to be thoughtful in who undergoes baclofen pump sort of treatment. So there is a patient selection process. Frequently, this is going to be coordinated through a physical medicine and rehab doctor, or maybe a neurologist. The neurologist or physical medicine and rehab doctor are going to work side by side with a neurosurgeon, and they're going to take a look at how serious is your spasticity and your spasms, how much is it impacting your life, what other treatment options do you have, and would you be a good candidate for this? There is a screening procedure. So you can do a test dose, and this can be done one of two ways. In some facilities, they will do a spinal tap or lumbar puncture and just give you a dose of intrathecal baclofen that would mimic sort of what the pump is doing. And so they're going to see if that dose gives you the response you'd like to have. In other places, they're going to sort of do a temporary pump. So they're going to have the sort of the tubing sort of external, and have you hooked up to an external pump and let you do that for 24 hours to see if this gives you, again, the results that you want. If that all looks good and it does what you want it to do, and you're a good surgical candidate, then they go to stage 3. They're going to put that pump in, and then there's the maintenance phase. So typically these baclofen pumps hold about 3 months worth of the concentrated liquid baclofen. So you're going to come back and get refills on about an every 3-month basis. If you don't like the baclofen pump, hopefully, if we're selecting people appropriately and you've had a good trial, you're not going to have to reverse it, but they can be taken out. In theory, there are fewer side effects with intrathecal baclofen than with baclofen by mouth because it's getting right where it needs to be. These pumps are programmable, so you're going to sort of adjust the dose, based upon the individual needs, and they are pretty effective. You can have MRIs with a baclofen pump in typically we're going to want to stick with the standard MRI or the 1.5 Tesla machine. These pumps are sometimes not approved in stronger machines and 3 Tesla machines. It really depends upon the facility. After you have an MRI with one of these pumps in, you're going to want to have what the pump what we call interrogated. So that means the nurse is going to take a look at the pump, look at the computer programming, and make sure that we've not altered how that pump is working with the magnetic field of the MRI. So potential side effects, sometimes they work too well. You could get hypotonia or too loose. If the dose is too high and the baclofen is now going into the brain rather than just the spinal cord, you could have drowsiness, nausea, vomiting, dizziness. Headaches are overdose is rare with these, but if you somehow really got too much of it, you could have respiratory depression or loss of consciousness. Again, quite rare that you would see these things. If the pump starts running dry and let's say you've missed a refill appointment, there is an audible alarm. Just like withdrawing from larger doses of oral baclofen can be dangerous due to seizures, letting your pump run dry and go for long periods of time with no intrathecal baclofen could be quite dangerous and even life-threatening due to seizure risk. And with that, I will stop. Hopefully that's kind of giving you an overview of spasticity and spasms and some of the treatment options that we have for that. So Chris, with that, we'll open it up to Q&A and see what thoughts people have.
All right. Now that we're going to open it up for some questions, I'd like to let everybody know that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute to ask your question. So our first question is from Carolyn. You sort of addressed this earlier, but her question came up before you got there. She wants to know, what is your opinion of cryotherapy, and can that help with spasticity?
Yeah, so the data says that it can. So the idea with cryotherapy is you're actually damaging the nerve and the nerve supply to the muscle. So the idea is you're no longer able to send that sort of excitatory sort of signal from the nerve to the muscle. Just like with Botox, where you want to be thoughtful in what muscles you're working on, because in theory with the cryotherapy, you're going to make that muscle weaker probably. So you're sort of exchanging control of spasticity and spasms for potentially some weakness. So you want to be very thoughtful about what muscles you're working on. There is a fair amount of research out there on cryoneurolysis for spasticity management. I'm not sure where we're at in FDA approval for that. And the reason I keep coming back to the FDA approval is, sometimes that has an effect on whether insurance is willing to cover the procedure or not.
All right. Our next question is from Sherry. Sherry, can you hear us?
Yes, I can.
Go ahead and ask your question.
All right. I tried many of the baclofen doses and many different antidepressants that you had mentioned over a year and a half, and they didn't work, unfortunately for me. Didn't want to go to the pump at this time, but just tried maybe they call it off-label, but it's called protriptyline antidepressant. Twice a day, and the ropinirole for the RLS. And this last 4 weeks, I'm seeing quite a decrease in the spasms. And I wanted to know your opinion of trying something like that and seeing if it helps other people.
So you raise some interesting points. So reprenolol or Requip is something that was designed really for Parkinson's disease, but it's used in restless leg syndrome. And a lot of times the symptoms that people describe with classic restless leg syndrome really sound sometimes like what people with spasticity and spasms deal with. So it's not always exactly clear in a person with MS. Could it be that there's a little bit of restless leg thrown in there? So I think if a person has failed a lot of the things we've mentioned today, it's not unreasonable to try out something like reprenolol because of that overlap between the spasticity symptoms and restless leg symptoms. So the protriptyline, you wouldn't think it would be a direct antispasmodic agent, but remember we mentioned how a lot of times spasms are worsened by underlying pain. So let's say the person had some neuropathic pain from their MS and that's driving some of their spasticity and spasms. So maybe in someone like yourself, your spasticity spasm control gets better with protriptyline because you're addressing something that was irritating it. So again, I think any of these things are reasonable options. And so I think, when we look at how variable MS is from one person to the other, one person's magic, bullet may be different from someone else's, but good for you that you've stuck it out and found something that seems to be working.
Okay, thank you.
Absolutely.
And I want to just thank you for your participation. And we're going to move on to our next question, which is from Desiree. She asks, is there a way to accurately determine if someone is experiencing spasticity for other than knocking joints? How do you determine if an oral medication is helping?
So, we mentioned that sometimes how people describe spasticity is difficult for them. So, on examination, your neurological exam, your neurologist, your healthcare team, they should be able to determine whether you've got spasticity just by your physical exam. So there is something out there called the Ashworth score or Ashworth scale that is a measure for spasticity, and it usually involves just moving the person's joints and seeing if there is this resistance to velocity to moving the joint. Spasticity that we see in MS is different from the rigidity that we see in, say, Parkinson's disease. So, even though they both cause a limb to be stiff, that they technically are different and they feel different on physical exam. If we get really fancy, if you're, say, working with a physical medicine and rehab doctor for botulinum toxin injections, they can do needle EMG recordings to actually record the muscle overactivity. But we don't typically need to do that for diagnosing spasticity in a person with MS. So how do we know if an oral drug is working? Well, I mean, we want it to either make the muscle looser or decrease spasms or both. So it's really kind of partly the subjective reporting from the individual experiencing the symptoms. Am I having less spasms? And then the physical exam, does the joint feel less tight or less spastic? In some research, when they're looking at drugs or other therapies for spasticity and spasms, they actually have study subjects do spasm counts. How many spasms am I having in a typical day, and keep a diary and see if it's decreasing with whatever the treatment is.
Just a reminder, everyone, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute to ask your question. And our next question comes from Jim. Jim, are you out there?
I'm here.
Go ahead and ask your question.
Hey, Chris. Hey, Captain Jack.
How are you doing?
I'm good. I do take baclofen and tizanidine. I have to be careful that if I get too much of one or the other, I do get that sleepy and jello feeling. My thing is, years ago, I was tested with a evoked potential test, where they sent the signal from the neck down to the right foot because I was right side weak at the time. The send signal timing was good. Return signal was slow. So the muscles, they said, were pulling against each other. And by flexing my toes and holding it for like a 5 count, I can almost feel the reconnection. And when I do, the spasticity and the pulling of the extremities against each other seems to lessen. Is there anything for increasing the communication timing that you're aware of?
So we think that exercise, just regular movement, might do a couple of things. It helps with the stretching of things. It may actually promote neuroplasticity. So you may be helping form new pathways so that you have more normal signals, kind of going from the extremity up to the spinal cord and brain and back down again. So
That's what the physical therapist talked about by the fact of the flexing like 5 times and holding it. I was reestablishing the link.
yep.
Uh, but is there more of a permanent, or is that something that I just
Well,
have? I stay on top of it when I feel it. That if I'll just subconsciously nowadays, I've done it so much that I will catch myself flexing and holding um, something to reestablish. Was just wondering if there's been any research of or anything, on topic or off topic that would help with the neural pathways.
So I think when we're doing stretching or you're doing exercises that might improve neuroplasticity, it's probably going to be an ongoing thing.
Okay.
I don't know that we know for sure. If you are reestablishing pathways, are they permanent? We would like to think so, but I think it is. We do like to keep up with the exercises because things do tend to tighten up and people decondition. There's just so much negative to not moving in a person
For
with
me,
MS.
it is atrophy. Seems to bring it up, and I am heat tolerant and cold tolerant. So give me 70 degrees and I'm okay. Above and below
Yep.
that, living
So,
in Atlanta, that's not an option
yeah,
except for like
70
2
and no
weeks.
humidity. Yeah.
Yes, not in Atlanta, but
Yeah.
yeah, I think it is a not a permanent when I do the flexing and stuff. It's a temporary reconnection. So I was just looking to see, um, go ahead and continue with that if it's working
Yep.
for me, obviously, to continue. But I just
And
wanted to see if
obviously,
you had any input.
we'd love to have something that fixes the damage permanently, and that it's coming. We've said in other programs how there's so much research on neural repair. We're not quite there yet, but I do think we will be.
All right. Thanks, Doc. Thanks,
Take
Chris.
care.
All right, thank you, Jim. Thank you for participating. And we really appreciate it, and we're going to move on to the next question. This one is from Anonymous. Anonymous wants to know, are there any supplements that will prevent muscle spasms?
So some people think that magnesium is of some benefit. We use magnesium for a lot of things in the neurology world. It's been shown to be a good migraine preventative in some people, but some folks will take a nightly dose of magnesium and they do think they have fewer spasms. So I don't think that would be an issue. With magnesium, you do kind of want to watch your bowel function. If you get too much, you're going to have loose stools. Many people with MS tend to live at the other side of the equation. They tend to be a little bit more on the constipated side. So sometimes one of the advantages of taking a little bit of magnesium is you may actually help with bowel function as well. Really, I think that's probably the only supplement that we see that consistently that might reduce spasms for people with MS.
Our next question comes from Elisa. When I was a child, I experienced clonus if my bent leg was in a certain position. Was this a sign that I would later develop MS?
So there's a normal human range of deep tendon reflexes. So we grade reflexes from 0 to 4. Most 4 is clonus. Most people live at about a 2. There are some people who just have very hyperactive deep tendon reflexes. So I don't know that having clonus as a child would necessarily have been a sort of a predictor of MS later in life. There are other things it could cause clonus. So there are mild forms of cerebral palsy, for instance, out there that people could be born with that really don't limit them significantly, but could be just enough to give them a little bit of clonus. So I would say that's in the maybe. The maybe it was a sign of things to come, but not necessarily.
All right, just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your questions anonymously if you so choose. Or you can ask your question by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you'll be able to unmute to ask your question. Our next question is from Janice. How do you treat an acute spasm, such as when your great toe and your foot curls up, causing pain and stiffness?
Yeah, so when you have that really bad sudden spasm, if you yourself can gently pull that toe back or in the foot back, or have someone else do it slowly and gently to try to break that spasm. Unfortunately, there's really not an oral medication that we can give you that's going to work quickly enough. So anything we give you by mouth, whether it's baclofen, tizanidine, even a benzodiazepine like clonazepam, it's probably going to take 30 minutes to really to work for you, and by that time that spasm's probably already run its course. If you did some sort of inhaled THC, that's probably the fastest thing that we could do. So that, I mean, that is an option depending upon where what part of the country you live in and the legalities of that. But I think just slowly and gently trying to stretch it out is probably the fastest thing you can do to try to break that spasm.
Actually, I had a question for you, and it goes back to the occupational therapists. Um, how do you find an occupational therapist who specializes in MS, and what do you look for?
So you'd like a neuro occupational therapist. So with both physical and occupational therapy, some tend to specialize more in orthopedic things, which is probably not going to be ideal for a person with multiple sclerosis. So you can just be very honest. You can call up a therapy place, and and ask them, do you have someone who's a neuro specialist? If they work in the neurology world, so the spasticity and spasms and issues with activities of daily living that someone deals with MS versus stroke versus traumatic brain injury, they're going to be very similar. So there is a lot of overlap between the issues that people are dealing with. Talking to your healthcare team, your neurologist, your team there, they might be able to point you towards therapists that are specifically knowledgeable in multiple sclerosis. Talking to your support groups in your area, to talk to other people with MS. Say, hey, who have you used as a therapist who's really good with this? The National MS Society may be able to give you some guidance. They frequently have referral lists for your area where people have identified themselves as having some interest and knowledge base in multiple sclerosis.
Our next question comes from Anonymous. Does MS spasticity only occur in arms and legs? How about the neck and back?
So any muscle is fair game. That's a good question. So it tends to be more common with the arms and legs, but anything is fair game. It's interesting with the trunk. So it can go a couple of different ways. We see some people that with their tightness, they tend to want to flex at the hip. So they're like, if they're trying to walk, they tend to be in a more bent position, whereas other people can have extensor spasticity. So they'll arch their back and really straighten out. So yeah, you can't, any muscle is fair game for spasticity.
Just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you'll be able to unmute to ask your question. The next question I have for you actually comes out of a comment in the chat. the individual mentions that THC causes foot spasms for them. Is there a relationship between THC and
So typically we think of THC as being anti-spasmodic. On the other hand, just like there's tremendous variability and tolerance for baclofen and tizanidine, an individual's response to THC may vary from one person to the next. So it would be unusual for THC to worsen your spasms, but I wouldn't say it's impossible for it to do it. When people are using cannabinoids like THC, we give them the same advice that we do with baclofen and tizanidine. Start with a very low dose, titrate upwards, see what benefits you're going to get, or you're going to run into side effects that are going to be unacceptable.
as a follow-up from Facebook, you mentioned that some THC products that may help for an immediate response to spasticity pain. Would using a product such as this impact cognitive functioning? Because
Yeah.
I ask because I am still able to work full time.
Yeah. So cannabinoids can be associated with cognitive issues. So the faster it gets into the brain, the more likely it is that you might have some cognitive issues. So you think about, when we think about THC use, some of the cognitive issues we see are a little bit of alteration of sense of time in some people. People will feel like time is speeding up or slowing down. You can see some slowness of thinking. You can see euphoria. And some people, they get this very unpleasant paranoia that comes on. When you inhale THC, it obviously gets across your blood-brain barrier into your brain a lot more quickly than taking it by mouth. It also probably leaves a little bit more quickly. So how that interacts with work, there are the legal issues of that, depending upon what your state laws are. There are your individual employer issues. Do you have random drug testing? I think, everything with spasticity management, like so many other things in MS, comes down to the risk benefit ratio. I think we can impair cognition in some people with baclofen and tizanidine. And so it's not like those are free of any cognitive side effects either. There was a study that a couple of years ago that looked at people with MS who were using cannabinoids like THC on a regular basis. And they did cognitive testing as a baseline while they were still using those products. And then they took one half of the group and had them stop their THC products. The other group continued their THC products. They repeated cognitive testing. I believe it was 3 months later. The group that had stopped the THC products actually had some improvement in their cognitive dysfunction. Again, and that's not an indictment of cannabinoids. It's just, we just need to be aware of the risks and benefits of in any treatment that we're pursuing.
Our next question comes from Anonymous. Is it possible to go off tizanidine, and how do you know if that's wise? What's an effective dose for most after on it for a while?
So tizanidine comes in both a 2 and a 4 milligram. I would say the average adult dose is probably 4 milligrams 3 times daily. We can go as high as 12 milligrams 3 times daily. So your maximum daily dose is 36 milligrams. The you know we think, how do we know if it's working? Well, it should reduce either spasms or spasticity. If it's not doing one of those things, then maybe you're not getting the benefit that you should with it. Um, we don't get as nervous about people withdrawing from tizanidine abruptly, but I would say if I had someone on a 3 time a day dose, just to be on the safe side, I probably would have them go to twice a day for maybe a few days, and then once a day and then off, just to be on the safe side.
I just want to take this moment to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you'll be able to unmute to ask your question. And our next question comes from Deanna. Um, I'm not sure if this has been addressed, but what about foods or beverages? Does dehydration affect spasms? Drinking too much caffeine or are any natural supplements helpful in management?
Yeah, I think on the last part, the supplements, I think really magnesium again that we talked about earlier would be the only thing that I've been significantly impressed with is maybe helping with spasms. Remember we mentioned noxious stimuli, things that bother your body. I would put dehydration in that noxious stimuli. So if you tend to be dehydrated, you may find that your spasms or spasticity are a little bit worse. Um, Anything again that kind of takes you out of your normal homeostasis. I think when it gets to individual foods or caffeine, that's going to be very individual. So, just listen to your body. If you know where your spasticity and spasms typically are, and now you have a day when they're really acting up, think back. Do I have an underlying infection? What did I do? Am I overheated? Am I overly chilled? Did I eat something, more or less of something? Just that you may have to do some individual detective work to see if for you individually there are certain stimuli that are helping to contribute to your spasms. Don't overlook constipation because I've definitely seen spasms and spasticity get worse with constipation as well.
Our next question comes from Barbara. She wants, first of all, to let you know that I'm not asking for a medical diagnosis. If I'm sitting or laying down, my quads feel fine. When I get up to walk, they feel like they're encased in cement. Is that more likely a spasm or stiffness?
So that is probably extensor spasticity. So some people describe it as almost like a Frankenstein leg, sort of feeling that when they stand up, their legs are just driven into the ground, and it's almost like they're magnets on their feet that it's more difficult to move. So I would suspect that is in the spasticity family. That's a situation where I would definitely, if she's not worked with a physical therapist, start there to try to really get into a good stretching program, and then if that's not covering that, helping with that symptom, then start looking at your oral medication options.
Our next question comes from Lisa. Can endemia, or I'm going to mangle this, lymphedema of legs affect spasticity?
Yeah, so if in people with multiple sclerosis, because the muscles are weaker, a lot of what gets fluid out of our legs is muscle contraction. So if your muscles are weaker, you don't have the normal contraction, so fluid may pool, especially if your feet are lower, you're sitting or you're standing up, that sort of fluid is going to go where gravity is going to let it go. Again, I would put edema and lymphedema in that sort of category of noxious stimuli, that if something is irritating your legs and you're prone to spasticity or spasms, that lymphedema is probably not helping with your spasticity.
All right, and now for our last question. This comes from Anonymous. I am taking Botox treatment in my head and neck for severe burning, neuralgia, facial spasms, and pain. Is it safe to take Botox every 3 months?
Yes, so Botox is safe every 3 months. There is a maximum dose that humans should receive. I would almost guarantee you someone getting Botox, for head and neck issues probably isn't coming anywhere close to the maximum dose. It's usually you start getting towards maximum dosing when you're doing big muscles like in the legs. So yeah, 3 months is the typical duration for Botox, and so that's a pretty typical regimen for people to do.
All right, and actually, it looks like we might have time for maybe one more question.
Sure, knock it out.
All right, this is our actual final last question. In regards to a baclofen pump, how long is post-op recovery? How long is a typical hospital stay? And the line inserted into the spine makes me nervous.
So the safety of baclofen pumps is actually very good. So again, you're gonna get a trial before you have the pump put in. That's usually done on an outpatient basis. Normally, when you go in to have the pump inserted, I've seen people out after one night in the hospital. I would say 2 nights is probably a little more typical of a recovery. The incision is not big where the pump is put in, so recovery is typically pretty fast with baclofen pump insertions.
And that will bring us to the end of our time today. If you've missed any part of this conference, it has been recorded and will be available through MS Focus Facebook and YouTube channels. Please reply to your registration email for information on how to access recordings or sign up for our newsletter to learn more about upcoming events. Also, you'll be receiving a short survey when you leave the conference. We greatly appreciate your feedback, which helps us determine what type of information is most helpful and meaningful to you. Be with us next time when our teleconference will be on Wednesday, June 18th at 5:30 p.m. Eastern. Our guest speaker will be Dr. Herb Karpatkin, and he'll be participating in an hour-long Q&A entitled Ask the Physical Therapist. We want to extend our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower, who takes time out of his busy schedule each and every month to educate all of us. Enjoy the rest of your day, everyone, and we'll see you next time.